Cardiac pathology, ischemic heart disease IHD, basic principle, group of syndromes related to myocardial ischemia. IHD is the leading cause of death in the US, usually due to atherosclerosis of coronary arteries, which decreases blood flow to the myocardium. Risk factors for IHD are similar to those of atherosclerosis. Incidence increases with age. Angina. Stable angina is chest pain that arises with exertion or emotional stress. Due to atherosclerosis of coronary arteries with more than 70% stenosis, decreased blood flow is not able to meet the metabolic demands of the myocardium during exertion. Represents reversible injury to myocytes, no necrosis. Presents as chest pain lasting less than 20 minutes that radiate to the left arm or jaw. Diaphoresis and shortness of breath. EKG shows ST segment depression due to subendocardial ischemia, relieved by rest or nitroglycerine. Unstable angina is chest pain that occurs at rest, usually due to rupture of atherosclerotic plaque with thrombosis and incomplete occlusion of coronary artery. Represents reversible injury to myocytes, no necrosis. EKG shows ST segment depression due to subendocardial ischemia, relieved by nitroglycerine. High risk of progression to myocardial infarction. Principal angina is episodic chest pain unrelated to exertion due to coronary artery vasospasm. Represents reversible injury to myocyte, no necrosis. EKG shows ST segment elevation due to transmural ischemia, relieved by nitroglycerine or calcium channel blockers. Myocardial infarction. Necrosis of cardiac myocytes, usually due to rupture of an atherosclerotic plaque with thrombosis and complete occlusion of a coronary artery. Other causes include coronary artery vasospasm due to principal angina or cocaine use, emboli, and vasculitis, for example, Kawasaki disease. Clinical features include severe crushing chest pain lasting more than 20 minutes that radiate to the left arm or jaw. Diaphoresis and dyspnea. Symptoms are not relieved by nitroglycerine. Infarction usually involves the left ventricle, right ventricle, and both atria are generally spared. Occlusion of left anterior descending artery leads to infarction of the anterior wall and anterior septum of the LV. Lead is the most commonly involved artery in MI. 45% of cases, occlusion of right coronary artery leads to infarction of the posterior wall, posterior septum, and papillary muscle of the LV. RCA is the second most commonly involved artery in MI. Occlusion of left circumflex artery leads to infarction of lateral wall of the LV. Initial phase of infarction leads to subendocardial necrosis involving less than 50% of the myocardial thickness. EKG shows ST segment depression. Continued or severe ischemia leads to transmural necrosis involving most of the myocardial wall. Transmural infarction. EKG shows ST segment elevation. Lab tests detect elevated cardiac enzymes. Troponin I is the most sensitive and specific marker. CKMB is useful for detecting refractions that occur days after an initial MI.